You know, the pancreas is an absolute master of multitasking. But what happens when its intricate machinery literally turns against itself? Welcome to this explainer. We're going to map out the complex, irreversible medical journey of chronic pancreatitis. Basically, we're taking all that dense textbook clinical info and turning it into a clear cause and effect narrative. By the end of this, you'll see exactly how just one internal malfunction triggers a massive cascade of systemic issues. All right, let's dive right in. So here's our roadmap for today. We've got 1. The dual-function pancreas. 2. Understanding chronic pancreatitis. 3. Assessing signs and symptoms. 4. Diagnosing the disease. 5. Medical and nursing management. And finally, 6. Patient education and complications. Okay, kicking things off with Section 1, the dual-function pancreas. Think of the pancreas as this highly efficient dual-engine machine running two totally independent assembly lines. On one side, you have the endocrine function. This is pumping out insulin and glucagon, which, as we know, is absolutely vital for regulating blood sugar. And on the other side, the exocrine engine. This one is churning out digestive enzymes, amylase for carbs, proteins for proteins, and lipase for fats, and sending them straight into the GI tract. When everything's running smoothly, it is a beautifully balanced factory.
Moving on to Section 2, Understanding Chronic Pancreatitis.
So what exactly is chronic pancreatitis? Well, it's characterized by chronic inflammation, fibrosis, and the gradual destruction of functional tissue. We need to be clear here. This isn't just a temporary flare-up. No, this is an irreversible physical degradation that permanently destroys the organ's ability to produce those essential hormones and enzymes we just talked about. And when you look at the physical progression of this disease, it's pretty staggering. Repeated inflammation literally turns vibrant, healthy tissue completely fibrotic. Over time, the organ physically shrinks, it scars, and it degrades, which fundamentally alters its actual shape and viability. It's a total transformation of the tissue. So what actually triggers all this physical destruction? Well, alcohol abuse is the primary culprit here, making up a massive portion of cases. But it's not the only one. Persistent blockages from things like gallstones, autoimmune processes, and even hereditary conditions, like, say, carrying the cystic fibrosis gene, can also spark this devastating chain reaction.
Now, because this is a dual-function organ, when that fibrosis takes over, patients are essentially fighting a two-front war. When the endocrine function drops, insulin production falls off a cliff, triggering diabetes mellitus. But at the exact same time, the dropping exocrine function severely halts enzyme production, which leads to massive malabsorption. It is a complete, total, systemic breakdown stemming from just one central failure.
All right, let's look at Section 3, Assessing Signs and Symptoms.
As the system starts to fail, we see this really rapid-fire cascade of symptoms across the board. In the hepatic system, a buildup of bilirubin gives us jaundice and dark urine. Genitourinary impacts, well, you get the onset of diabetes, which leads to polyuria and glucose spilling straight into the urine. And the GI symptoms just hit incredibly hard. We're talking anorexia, massive weight loss, and this agonizing, recurrent epigastric pain that can literally last for weeks at a time. There's one highly specific, absolutely critical clinical red flag you need to watch for, and that's steatorrhea. See, without lipase, that's our fat-digesting enzyme, fats just pass directly through the GI tract completely undigested. The result? Fatty, frothy, really foul-smelling stools. It's essentially visible confirmation that the exocrine assembly line has completely shut down.
Next up, Section 4, Diagnosing the Disease.
72 hours. That is the exact window of time we need for a comprehensive stool collection in the fecal fat test. By meticulously measuring the grams of fat in the stool over this 3-day period, we can definitively confirm the total absence of digestive enzymes. It's a heavy lift for the patient, but it's crucial.
Now, alongside that 72-hour test, we use ERCPs, MRIs, and CT scans to really visualize the internal scarring. We'll also run blood work to check amylase and lipase levels. But here is the crazy clinical paradox. In chronic, late-stage cases, these enzyme levels might actually come back completely normal. Not because the patient is healthy, mind you, but because the organ is so completely burnt out, it literally cannot produce enough enzymes to elevate those blood levels.
Okay, moving right into Section 5, Medical and Nursing Management. To relieve the immense internal pressure from all those blocked, inflamed bile ducts, a biliary drain is often placed directly into the system. This basically acts as a mechanical bypass.
It drastically improves enzyme drainage and really decreases the frequency of those severe, painful attacks.
When it comes to nursing care for this drain, it has to be absolutely meticulous. The steps are non-negotiable. First, you inspect the site and change the dressing as needed. When flushing the drain with 10 milliliters of normal saline, there's a strict rule. Never, ever withdraw fluid. If you meet any resistance, you stop immediately and notify the provider. And for standard maintenance, you must empty that collection bag right when it hits the 2/3 full mark to prevent any dangerous backup.
To artificially replace that lost exocrine function, we use pancrealipase. And guys, the administration rules here are incredibly strict. You have to give it with or right before meals, it must be swallowed whole, or you can sprinkle it on non-protein food. But crucially, the patient has to rinse their mouth and wipe their lips immediately after. Why? Because these are active digestive enzymes. If they get left behind, they will literally start digesting the oral tissue. No joke.
And speaking of pancrealipase, it carries a severe clinical red flag. Prolonged use of doses greater than 6,000 units of lipase per kilogram per meal significantly increases the risk of fibrosing colonopathy. We have got to stay hypervigilant for signs of this. Things like severe abdominal pain, bloody diarrhea, and a thickening of the bowel wall that usually predates severe strictures.
Then we have to deal with the reality of the pain. Due to the intense, prolonged agony of this disease, and remember, these episodes can go on for weeks, standard pain relievers just do not cut it. Patients often require really heavy opioid analgesics, like morphine or Dilaudid. This introduces a very real medical balancing act. There is a huge risk of drug tolerance developing because of the high doses required. Plus, these opioids cause severe constipation. That means the aggressive use of stool softeners isn't just a suggestion, it is an absolute requirement in the nursing care plan.
Finally, let's wrap up with Section 6, Patient Education and Complications.
Education is really the bridge between the hospital and the rest of the patient's life. The rules moving forward are absolute. We're talking a strict zero-tolerance policy for alcohol. They need strict dietary control to manage newly acquired diabetes and hypervigilance regarding those opioid addiction risks we just talked about. And clinically, the monitoring never stops for life-threatening complications like pseudocysts or abscesses.
So it all comes down to this big question. Can the damage to the pancreas be undone? Unfortunately, no. This inflammatory destruction and fibrosis, it is completely irreversible. That stark reality makes early intervention and rigid, lifelong management the absolutely only path forward. It's a profound reminder of the delicate balance of our internal systems, and it really begs the question, what other silent internal battles is the human body fighting, long before the very first symptom ever appears? Thank you for exploring this with me in this explainer.